It's an important message for everybody. If there are questions, please put them there and we'll try to answer everything. So next speaker will be Arjan Kumar Khaim from India, from Bangalore. He is the course director of the IWAS course there. Unfortunately, this year it doesn't happen, and we will hope that next year it's getting better with this pandemic. Please, Arjan.
Okay, I'm visible now?
Yes, it's good.
Yeah. Thank you, IWAS. Thank you, Eva, as well, for this opportunity. And I would mainly speak on the diagnostic part of the arthroscopy. So this is where I come from. It's from Bangalore. It's the southern part of India. So we conduct the IWAS courses here from last 4 years. So this year was a mess. Hopefully we'll be able to do next year as well. So once we speak about the diagnostic part of the arthroscopy, usually a good physical examination gives us a much of the almost 70 to 80% of the time a good diagnosis, or we'll be able to reach to a diagnosis. But whenever the pain has persisted despite a non-operative management of its splinting or even some therapy, then after the imaging as well, you're not able to localize, then that is where the role of a diagnostic arthroscopy falls in. And to start with this, you need to know the knowledge about the arthroscopic anatomy is quite essential. So these are some of the studies which says the efficacy of the MRI and the clinical test and diagnostic of wrist ligament injuries. So one of the study was in 2015, which concluded like the negative results of MRI or clinical provocative test are unable to safely rule out. The word was very clearly mentioned. It's unable to safely rule out the possibility of a clinical relevant test. And these three were the main, usually the most common culprits or the offending issues, like it's a TFCC, the scapholunate, or the lunotriquetral ligament injuries, which makes some of that. That's where the diagnostic role of the wrist arthroscopy starts. So as Michelle was mentioning, the portals and the holding of the scope, like portals are key to successful arthroscopy in any of the arthroscopic procedures. And in wrist, these portals are named based on the interval between the compartments. So basically we start doing with the radiocarpal and the mid-carpal joints, and sometimes DRUJ portal as well. So I will speak about the most commonly used portals, that's the radiocarpal and the mid-carpal portals. So this is how the portals are seen as, or you mark the portals. Basically the listus tubercle is the key point, and the ulnar styloid process is these two are the landmark for us to start with the portals. And the most common portals of the radiocarpal joints are the 3-4 portal, that is the interval between the third and fourth extensor compartment, the 4th, 5th, or the 4-5 portal, and the 6R portal. And that these three are for the mainly used for the radiocarpal joint. And for the coming to the mid-carpal joint, this is the STT, MCR, and MCU. That is, MCR is the mid-carpal radial portal, and mid-carpal ulnar portal. These two are most commonly used whenever we are trying to address the scaphoid non-unions or towards the scaphotrapezoid joint. This is the scaphotrapezoidal portal. This is the STT portal which we use. So when you are starting up your marking on your portals, these, at least the listus tubercle you mark and the ulnar styloid is the key. When you mark them, that is sufficient. You don't have to draw the entire anatomy. And please, it's always better to mark all the portals before you start a wet arthroscopy or you irrigate the joint with, because the landmarks might be difficult after some time. Coming to the most common portal, this is the workhorse of the portal, that is the 3-4 portal. Usually it is 1 centimeter distal to the listus tubercle, and one should be careful that this is one you could damage the EPL tendon as it just runs on the towards the radial side, and this is the first portal of choice for many or most of the arthroscopic procedures. Next is the 4-5 portal. This is in line with the 4th metacarpal and slightly proximal to the 3-4 portal. And the 6R portal, this is just radial to ECU, but usually this is done under the direct vision. When you are viewing through the 3-4 portal, it's easy to mark the 6R portal. It's 5 millimeter distal to the dorsal part of the TFCC, and this is usually a main working portal. And these are the common cutaneous nerve which are addressed, you can see, which will be discussed probably in the next talk. Most commonly is the radial cutaneous nerve, sensory branch, and the dorsal cutaneous branch of the ulnar. That is, this is the ulnar branch, and these are the radial branches which are commonly injured. or which could be injured during your portal when you're making the portal. So when you're making a portal, these are the key steps. So you identify, as I told, these two are the landmarks which you need to mark. You could use a needle, or you can directly palpate it and then use the blade. Usually 15 number blade is one thing which you use, and don't plunge the blade inside because you could damage. You just have to make a small incision up to you reach only the subcutaneous tissue, and then your artery is the friend that which you need to dissect out the soft tissue underneath and reach to the capsule. And always remember, this is the entry angle, because even before you put the scope, when you're introducing your artery, some people use a curved artery, some people prefer to use a straight artery, but this is the angle which you need to enter, because you're working, your scope is going to enter this way. So first you palpate. So you palpate the Lysis tubercle. This is an individual who had a wrist problem, and that's the portal. I'm just palpating that and slightly towards distal. This is how you introduce a needle towards your radiocarpal joint. And you're making the 6, and this is for the third 3-4 portal. You just make a skin incision, use your artery, close the artery before you introduce into it. Then you could just dissect out soft tissue. There's adequate traction, so you could even, the joint could be easily seen. Then you introduce your camera that and once you make that, you make the 6-hour portal under direct vision. Once you insufflate the joint, you could use the dry or the wet one, irrespective of it, whichever is convenient for you. You should take care that you don't go and damage the TFCC. So you should be just above that. That's how you make the 6-hour portal. And this is another part which portal which is made is the STT portal. That's the radial. This is on the radial margin of the index metacarpal, just ulnar to the EPL tendon. This is a radiocarpal view of, because one needs to know about how it looks under. This is the scaphoid fossa on the radius. This is the lunate fossa on the radius. This is the TFCC, where this 6-hour portal will be there on this side. This is the scaphoid, lunate, and the triquetrum. And the mid-carpal portal, as I told, this is the MCU portal and the MCR portal. And some of the salient features, the depth of the mid-carpal joint is less than half of that of the radiocarpal joint. That means it's much more tighter. So you need to take care, and your angle of entry, you need to pay respect to that, or else you could cause osteochondral injuries. The MCR portal is 1 centimeter distal to the 3-4 portal, in line with the radial margin of the third metacarpal, which is bounded radially by the ECRB and ulnarly by the 4th compartment. And the MCU portal, this is basically 1 to 1.5 centimeter above the 4-5 portal in the 4 corner intersection of these 4 joints. That's the lunate, triquetrum, hamate, and the capitate. It is bounded radially by the EDC and ulnarly by the EDQ, and that which is palpated as a soft spot. So when you see towards the mid-carpal portal, you should know this is much more, the curve or the arc is much more acute. So you need to keep this focus. You need to introduce and you angle the camera to see on this part as well, or else you could, again, it might be difficult for you to visualize or else you'll directly hit this bone here and you'll not be able to go through this curvature. So principles of the sequence is quite important. For example, this chimera, when you see from this angle, you see 4 limbs. This was taken in the London Museum. Whereas when you see from here, you see the 2 limbs only. But when you see from this angle, you see 5 limbs. So this tells us the sequence of visualization, how critical it is when you are seeing, observing, and rotating your scope to get the view of this thing, which was Michelle was mentioning about how you rotate your light source and your camera to get the visualize. That's quite important, which just comes, or the triangulation which comes only with the time. So holding the scope, which was already mentioned, so try to hold it like a gun and place your camera on your first web space like this, and with your finger directly resting on the finger on the patient's skin. This is a correct way. Some of the principles, you follow one of these sequence, whichever is comfortable, but you have a sequence so that you visualize. It's easy, you don't miss out any of them. Radial side before the ulnar side, distal before the proximal, and the volar side before the dorsal, ligaments before the articular surfaces, and the inspection before probing. So this is a small video on the on the diagnostic round of the wrist arthroscopy, which I'll showing you. So basically, this is the radiocarpal joint which you're going to see, and it is a view through the 3-4 portal, and this is a diagnostic round. You're viewing through the 3-4 portal. That's a radioscaphocapitate ligaments. That's a scaphoid. You go, this is a long radial lunate ligament. You go towards the ulnar side. After you visualize, this is a dry scopy. So once you visualize, slowly you move towards your ulnar side. So this is the leash of vessels, which you call pseudo ligaments or the ligament of test tube. Then you go further ulnarwards. That's a short radial lunate ligament, what you visualize. Further ulnarwards, once you go, you see the TFCC here. This is the border of the TFCC. This is the pre-stylodrasis. Probably a small rent is here, but insignificant. Then you see these are the ligaments on the ulnar side. You come back again on the radial side. That's the articular surface of the radius you see. Then this is the radial side attachment of the TFCC. Going towards, again, back towards the radial side, you see the proximal pole of the scaphoid. You follow all along the radial border of the scaphoid. Going up. You see that it's healthy here. Once you go again down, this is scapholunate interosseous ligament, which you need to differentiate. This is scaphoid here. This is the SLIL, and this is the lunate here. So basically, when you are looking for the diag, you need to look in the radiocarpal as well as mid-carpal joint when you're suspecting a scapholunate ligament injury. So further, once you go ulnarwards again, now you palpate. That's a dorsal capsule, because this area where you have to see the reflections where you're trying to look for the dorsal wrist ganglion. You need to come along, and this is a 6-hour portal. You palpate under direct vision. You do it. Align your camera. Then you make that's a 6-hour portal. Introduce a needle there, and your mosquito there. And then you feel with the probe, you need to feel for the trampoline effect. That's, you need to feel the good tension on the TFCC. If there is the tension is good, that's called a trampoline effect. That means the TFCC is intact. If it's lifting off easily, you try to hook it. If it's lifting off easily, that means that the foveal attachment is gone, or the capsular attachment is also could be injured. So you need to feel for that effect. Next is a mid-carpal portal. You're viewing through the mid-carpal radial portal. So once you introduce your thing, that's the capitate and the hamate, what you saw. You withdraw your scope because you were quite deep inside. So next, you visualize that's the scapholunate interosseous ligament, scaphoid lunate. Then you go further. This is the LT interval lunate. That's a triquetrum. You could follow further to get the hamate view there. Again, you can go back towards the real side, because when you want to look for the STT joints as well. So you could see a part of it. That's the trapezium and the trapezoid. There's the distal pole of the scaphoid following along the waist. You go there. That's trapezium and trapezoid. That's this joint there. So this was a basic diagnostic around what you see in the. So some of the diagnostic dilemmas, as I mentioned, is quite commonly is the partial SL injury and or during the ulnar sided wrist pain when you have a LT injury, when you suspect them, or the TFCC injury. So this is how you assess the scapholunate interval. You probe it properly. You try to introduce it. Sometimes you might be introduced, but you may not be able to turn it around. That shows that partial injuries could be there. But here in this case, this is a healthy scapholunate injury. That is how you need to assess the scapholunate interval. This is a visualization of the partial. This is a case of partial SL injury. You can see this. You are viewing from the radiocarpal joint. This is scapholunate interval. That's saying ligament here is quite good. You feel that, but you need to, now you are seeing through the MCR portal. So you could see that you can ballot it. You can try to push the lunate there, and you can probe it through your this thing. You can see now through the MCU portal. So the volar part of the ligament is injured, whereas you slowly withdraw your scope. Then you can see the dorsal part of the ligament that seems to be intact, which is the most strongest part of the ligament. So this gives you an idea whether you need to intervene, or is this the cause of the pain. When you see this thing, this is how you need to probe, and once you can make out the scapholunate interval as well. These are the other LT injuries you can see here. That's this lunate. This is a frank injury. You can see the MRI was normal, but still you could see this is the kind of X-ray. A 3 Tesla MRI also could not pick this up, and it was reported as normal. That's quite commonly seen, this problem. So you could see you can rock the trichoterm through your probe, and also you could ballot it from outside. This is, I'm doing a ballotment from outside. You could see the gap is so widely opening up when you do a ballotment test. So which shows that this is an unstable situation that needs to be repaired or addressed. So similarly, you can see TFCC tears. This is some of these tears which was shown as normal. Here, the MRI reported was as normal, whereas you see a dorsal capsular tear was there. The trampoline effect is not good. You can't feel for those good trampoline effect. You could lift it off. That's a dorsal capsular tear. And here you can see the radial side tear. Even this was MRI was reported, as well as a softening. Patient had an injury, and then you could see the ulna. Then you could go along. You can see the redness erythema there, and you can see this is a softening of the injury. This was the cause of the pain, the ulna styloid along that margin. So you know next that you need to address these issues. So this is one of those where MRI is normal, and then you can see that the diagnostic arthroscopy is quite useful in these situations. And this is what the recording of or noting of all these things, findings apart from your photos or the videos. This is quite important. Once you make, this is what I use it, diagram where you can mark these specific ligaments or the bone. You can draw it after the surgery and make a note of it, which is useful for later on if at all you want to draw, means for any research academic purpose. Thank you. Thanks for the opportunity. Hope you enjoyed.
Thank you so much, Rajan, for being here. So some questions.